And then it is my honor to introduce Dr. Rachael Duncan and Dr. Stader. Dr. Duncan serves as the Associate Director of the Naloxone Project, and Dr. Stader is the organization's Executive Director. Today, they're going to join us to shed light on the issue of maternal overdose in Tennessee, share some insights into the impactful work their team has achieved in other states through the Maternal Overdose Matters or MOMS initiative, and discuss the critical role of naloxone distribution. I'll turn it over to you, Rachael.
Yeah, thanks for having us. And what a wonderful exercise to start the meeting. A lot of that really resonated with the type of work that we do here at the Naloxone Project. I'm going to take the next 10 minutes to just talk a little bit about the why and how we built maternal naloxone distribution programs. And then Dr. Stader is going to chime in here with what could be coming down in your own state, which we hope to be a part of. So just a brief agenda for these 10 minutes that we'll be looking at. And I just wanted to start us out talking about maternal mortality and making sure that we're all very aware of what we mean by that. And so to encompass really all of this range and different types of mortality, we call it pregnancy-associated death, right? And so that's going to include both pregnancy-related as well as pregnancy-associated but not related. But that all-encompassing term there is pregnancy-associated death. And I think it's really obvious when a woman is pregnant, right, that would apply to maternal mortality. But it's also after that pregnancy is over, whether it results in a baby or something miscarriage or the end of that pregnancy. The World Health Organization has historically defined that as 6 weeks, big focus on that 6-week postpartum checkup. But in the United States, we actually extend that out to 12 months. And some of this is due to our higher maternal mortality rates in general in the United States, and the fact that many of these are happening in that postpartum period. And when we kind of narrow in here on maternal overdose, this is statistics in the United States. And this was data looking at 2016 to 2020. So just the beginning of that first year of COVID that we all experienced, where 1 in 6 pregnancy-associated deaths, so while that person was pregnant or the year after, was due to an overdose. And you can see in this graph on the left, that was really driven by fentanyl, the orange line there, and other synthetics. We saw an evening out of heroin as fentanyl took over the market. And then this one on the right, I just have in here to show that really we saw this uptick, particularly in that late postpartum period. So after the 6-week checkup. And again, just wanting us to understand where are these deaths happening and that we have to stay really vigilant even after baby is here. Now in Tennessee, your data very much reflected that of the nation during that time frame, right? About 1 in 5 of your pregnancy-associated deaths in that time frame was due to overdose. And while the state overall has been able to actually start decreasing maternal mortality over the last couple of years, one place that we haven't seen that necessarily is an overdose. And in fact, it now accounts for 1 in 3 of your pregnancy-associated deaths in that 2020 to 2022 data. And so again, this is being driven by fentanyl, and it really highlights for us where we have to start making impact and change. And so again, just getting back at the majority of these overdose deaths happen in the postpartum period. And the greatest risk may actually be between 6 months and 1 year after the end of pregnancy. So I remember when I had my children, I had a lot of support around me in that first few weeks up to a couple of months, but then people start to disappear a little bit, right? There's less support around mom. And so I think this makes a lot of sense of where we're seeing these deaths. And so with this being a leading cause of pregnancy-associated death, and then we look at these and say, were these preventable? And almost all of these deaths are preventable, especially those involving opioids, because we have really effective treatments. And then we have an effective antidote, which is, as a pharmacist, incredible to me that we have that. And so we say, where do we start? How do we start preventing these deaths? And so to cut to the chase here, naloxone, right? Making this more available to new moms, to families, and out in our community is one of the key steps. And so I think historically in healthcare, we have written discharge prescriptions. So after someone was seen in the ER, right, following an overdose event, we'll discharge them with a prescription for naloxone. And it's available in every pharmacy now, and it's available over the counter with standing orders. And we've done all these things that we think will make it more available to our patients. And what we have found that in our highest risk patients, this is actually a really ineffective way. These fill rates are really dismal here, less than 1 or less than 2% in certain studies in high risk patient populations. And so it really tells us that this is not the best way to do this. And so we ask, okay, why aren't patients filling these prescriptions? And some of the reasons that come up are logistical barriers, payment, and then stigma still around substance use disorders. And then you put on top of that a parenting patient, and especially moms. And I think we put moms up on pedestals and really expect them to do it all. And so have additional stigma there. And so, how do we ensure that patients receive the education and are aware of overdose and have access to naloxone? And that's where Don and I get really passionate about this in building take-home naloxone programs and partnering naloxone and embedding it within medical spaces. And so the different things that this is able to do is risk reduction, absolutely. We know that when we put naloxone out into communities, it reduces overdose deaths by anywhere from 20 to 30%. It helps people use in safer ways and use less. And folks are more likely to connect with recovery services in the future. It also empowers patients and families to not only protect themselves, but be ambassadors in their community. And then also, we're always fighting to reduce the stigma associated with substance use. And so, normalizing naloxone by having it handed out from clinicians is a really great way to start. And so, we are part of a clinician led nonprofit called the Naloxone Project. Again, we really believe that medical spaces are the right spaces to have naloxone available in overdose education and pair it alongside everyday medical care as well as treatment for substance use disorders. And we have an initiative specific to the maternal population, which we call our Moms Initiative, really creative there, as you can see. And our goal here is really that birthing hospitals and obstetrical clinicians provide overdose education and hand naloxone directly to at-risk patients and families before they leave the hospital or that encounter. And how we have built this in other states and through birthing hospitals is often through this type of a training and timeline. And so it's putting the right policies and procedures in place to make this an easy thing for hospitals to do. It's building it within the EMR. It's providing staff education and training so your staff feel comfortable having these conversations. That video that you showed in the beginning, I think is a great example of, I think sometimes bedside staff don't have a lot of comfort. And so we need to give them the scripting tools that they need to make sure that those conversations go well. And then I would actually put pharmacy probably further up in this timeline here because pharmacy often has to be really involved with anything having to do with medications. And so what our organization does is really supporting states and hospitals and systems in this implementation by making sure that they have all of the tools that they need. And so on the right side here, we work with several PQCs, both in Wyoming, Colorado, Louisiana, Washington State, to do these types of projects and really make sure that before we go live with the maternal naloxone take-home program, that we make sure that all of the steps have been completed, right? We want to make sure that we have staff buy-in and training. We want to make sure that the process has been ironed out. And we always say, how do we make the right choice the easy choice for busy clinicians? And that's what we try to come in and help iron out those pathways before we say, let's go live and pilot this. And that's really what we're here to do. So who would go home with these kits? Well, take home eligibility, if you base it on risk, is really based on a few different things. If they use any type of a prescription opioid, that could be for chronic pain, that could be for treatment, right, with methadone and Suboxone, or if they're receiving a new opioid prescription after, let's say, a C-section, they should have the antidote in the house as well. If they use any type of illicit substances, and we really emphasize here not just illicit fentanyl, but also methamphetamine and cocaine, which can often be cross-contaminated with fentanyl, we want to make sure that naloxone is available. And then especially important in this population where I always say it takes a village to raise a child, is there anyone in your village that uses substances or has prescription opioids around? And we want to make sure that we have naloxone available for those families. This is often what a workflow will look like within a hospital. So again, I love that video where we're using a validated verbal screening tool like the 5-Piece Plus to universally screen for substance use on admission. That would help us understand some of that at-risk criteria. It would reflect an order in CPOE that would then populate on the EMR for the nurse. When the discharge process begins, that nurse could then pull that naloxone kit off of some medication storage placed on the unit, like a Pyxis or Omnicell, and then hand it directly to the patient along with the family on discharge. And that way that patient and family leave the hospital with naloxone in hand. I'm going to breeze through this here and just show you a little data point here on our work in Colorado, which is where we began this work about 2 years ago. And you can see over the past couple of years, we've now dispensed over 5,000 kits with an at-risk targeted criteria. And are really working with our obstetrical units here to get this out and make this available to new moms and families. And with that, I'm going to turn it over to Dr. Stader, to chat a little bit more about our continued and hope for our work potentially in the future.
Yeah, I want to just thank TIPQC for the invitation. It's always an honor for us to be invited into spaces where we can work with different great organizations across the country. And our goal, really, as our nonprofit goal, is to make this easy, to make this implementable, and then to really help you decrease barriers to implementing a process like this. And the exciting thing, I think, for Tennessee as well is you guys have a very large grant out to actually do universal postpartum naloxone delivery to patients. And really, we're eager and excited to partner with you guys as the state assigns whoever is to do that work. Whether we are winners of the grant or it can just be your best friends if you win the grant, right? We are committed to making sure that Tennessee moms and families have access to life-saving medications. And I think it's incredibly important given the mortality that we're seeing in Tennessee and across the country when it comes to overdose driving maternal mortality. There's no more important thing for us to address when it comes to keeping moms and families safe. So I'll just leave my comments there, and again, Anastasia, I don't know if you have time for questions, etc. But we'll put our comments, our names also in the chat, and please, if we can ever be of assistance to any of you, that is within our nonprofit mission, is to be of service.
Thank you, Dr. Stader and Duncan. Yes, we do have some time for questions if anyone has any questions for the Naloxone Project.
I did have a quick question. My name's Kim Lovell. I work with the Firefly program at Vanderbilt. We treat pregnant and postpartum women with substance use disorder and their families. So very on board with this mission and love the work that you're doing. I just had a quick question about data. And, I know you've probably been of course, you have data, a number of kits distributed. It may be too early in the process to have outcomes data about actual impact on overdose numbers from this effort, but curious if that exists either in your context or in other contexts similarly where this type of program is rolled out.
Yes, I love the question, Kim. I'm the nerd in the group that loves data here. And yes, often working with PQCs and state hospital associations to do as much of the data mining in the background as we can to take that burden off of individual hospitals. So looking at things like claims data to match up at-risk patients is a big part of what our organization does. And then looking at those more long-term outcomes, Kim, I love that you asked that because we actually just requested from our Colorado Department of Health more recent maternal mortality data to see, with the timing of the program that we've done here, if we've seen some decrease. And I'm not allowed to speak about it because it's unpublished, but it's looking really promising. And we certainly cannot take all the credit for that. It is a lot of different efforts for example, just Colorado as an example. But it is making a difference. But to your point, yes, yeah, I can't wait till we can share it because it's just so exciting. But for example, working with Louisiana right now, and they have about 48 birthing hospitals rolling this out to all of those hospitals, just kind of getting boots on the ground and getting it going after a pilot last year. We'll be tracking that data very closely with them. Both are the highest risk patients receiving this? Are there any disparities within that, right? Whether it comes to payer groups, socioeconomic status, race, things like that. Looking at rural versus urban is also another big one. Most states have quite a dichotomous range or are mostly rural. And so, yeah, hopefully that assures you around the data piece that we're big data nerds.
I will say too, Kim, to your question is we have some embargoed data that we can't share, but like Rachel said, looks promising. I will say that it's also going to be interesting for us to tease this apart from the secular trends that we're seeing in overdose across the country, right?
Yep.
So overdose across the country it depends on your community. Is generally, I think nationwide is down around 20 to 30%. And different states have, of course, different levels of decrease. So is this part of a secular trend or is this really due to interventions? I do think, though, that it's so important, and this is what Naloxone Project brings, right? It's not just about getting naloxone out into communities. It's about actually getting all the counseling that comes together with the naloxone. So, for example, if I had a mom who we knew had a substance use disorder, who was being home, let's say that they were separated from family because there was child welfare involvement, right? It's not only here's naloxone, but it's please promise me that you'll never use alone, right? Please promise me that you will call this hotline for never use alone if you are in a situation where there's no one who can be with you and keep you safe, right? And it's those types of messages that inherently demonstrate the value that that person has who's struggling, with also the techniques that they can use to not overdose that are really, I think, the magic sauce, and also allowing us as medical providers to again change this from something that is stigmatized to something that it is undeniable that we care for that individual, that family, and want the best for them, right? And I think that that's where we build those therapeutic connections that can have much better outcomes in the long term for those patients and for families.
Thank you. That was really helpful. Thanks.
I think we have time for one more question if anyone has one more question.
I have one. So we have a policy on a discharge for emergency rooms for the naloxone to be done. How do we get our OB doctors to do it? And they may be on, maybe they'll be encouraged. It is a policy that says, for them to have it at discharge, not write a prescription, put it in their hand.
I think, I'll take the first stab here, Rachel, is, I think that any physician and clinician who looks at those numbers of saying, hey, mortality is driven by overdose in our communities, in our families, should feel a call to action that, hey, we need to do something about this, right? Anytime we have a mom die is a tragedy and something that we know we can prevent with amazing antidote and really common sense, easy to implement counseling that we can do at the bedside. And I think that too, to give again a silver lining and hope, is it sounds like Tennessee and TIPQC are invested in and want to be leaders in bringing this change to Tennessee. And we want to be your best friends when it comes to figuring out how to do that. We've talked with a lot of salty ER docs to get them to do it. We can talk with a lot of salty OBs and L&D charge nurses too. And at the end, when you start doing this, I always ask people, would you want to stop? And they say, no, this is much better. This is the right thing to do. And it does have amazing effects. The last thing I'll say as a dad, not a mom, is the number one person who's actually saved when you distribute naloxone to moms, guess who it is? It's dad, right? So, and again, we've seen infant also overdose from parental exposure increase by, I think, around 400% across the country. So guess what? It can be kids too. So naloxone is really an agent to keep an entire family safe, and I think that's something we can all get behind.
Yeah, and to piggyback off that, Bonnie, I think it's some peer-to-peer conversations, right, with other obstetrical providers who are champions and/or nurses, and then getting back to like you make the right choice, the easy choice. It typically comes down to I don't want to have to remember to do one more thing, is what I find for 80% of clinicians, right? There are certainly going to be those that still have some stigma or issues with it, but if we can make it the easy choice, the right choice, and iron out those things, and honestly take that burden off of them, and just protocolize it, that's typically my strategy there.
So should it be if they write a prescription for opioids, they should also hand out naloxone?
Yeah, and what can we do to automate that, right? What can we do to just make that be an automatic
Can we just
thing?
get a vending machine? Sorry. Well,
we also do that too. We do a lot of vending machines. So although we've moved away from that. What's the term we're using, Don, instead of vending machines?
We're using just the stands. Stands for a second chance is actually the corny term that we use for them. But I would say that the one thing that vending machines do not do, though, is they do not provide that counseling, right?
Yeah.
Because again, it's not just about having naloxone, but knowing how to use it and knowing those safe practices of, hey, promise me you'll never use alone, right? Never use, like it's almost as important to naloxone. If I can just plaster that around, if you're using substances, never use alone, never use alone, never use alone, right? I whenever I have a patient, I basically make them promise me and look me in the eye and tell me that, or they'll call this number, right? And I think it's those really simple messaging techniques that will eventually save lives because people have the antidote and they have the knowledge of what's deadly. Drug use alone is deadly in 2025.
Yeah.
Anastasia, if I could just jump in. This is Brenda, and we did want, you've heard been alluded to that TIPQC is joining with the Narcan Project to apply for an RFA. We will need about 10 hospitals that are interested in universal distribution of naloxone and working with us for the next year and a half. We are so excited about the lives that are going to be saved, not just our moms, but also our dads. And so if you are interested in that, if you have your pharmacy on today with us or your hospital administration, please reach out to us after the call and just let us know that that is indeed something that you and your hospital would be interested in. And we'll get you an application and information in the next couple of days. So we're moving quickly on this, but we appreciate everybody that joined. I know we had our colleagues from the Hospital Association, thank you, that dropped everything to join today. So moving very quickly with this. And again, reach out with any questions that you might have. And I'm going to ask if you're with a hospital. Again, we so appreciate you joining us. Feel free to jump off now. Hopefully you got your questions answered. And I know we'll move on with the rest of our Best for All huddle. Thanks again, Don and Rachel as well for joining us. And hope everybody has a good afternoon. Everybody on the Best for All team, stay online. And we're going to look at your work as well. Thanks, everybody.
Thank you, Brenda. Thank you for the opportunity.